Joining me on today's episode of the Anthro Education Podcast is Dr. Kathy Dooley. She is a professor of anatomy at two different medical schools in New York. She's an adjunct professor at a dentistry school and a visiting professor at the West Sydney School of Medicine. In addition to that, she is co-owner of the gym that she practices out of in Manhattan, Catalyst Sport. She lives in Boulder, Colorado, and travels back and forth. Writes for her own website, Duly Noted, and is a lead instructor for the course that she co-created, Immaculate Dissection, as well as neurokinetic therapy. Well-accomplished person. I was lucky enough to have Dr. Dooley as my neuro professor in chiropractic school, and we get into a plethora of topics. So without further ado, Dr. Kathy Dooley. Well, first of all, let's, this is your second time on the show, and the show is, I think it was the Anthro, I don't even know what it was called back then. It's changed so many times, but it's back to the Anthro Education Podcast, which is the human education podcast. And now you're a guest for the second time. The first time I had to look back and see what we titled it. It was called Why Anatomy Matters.
Yep.
And if you haven't listened to that episode and you don't know what I'm talking about or who I'm talking about, joining me is, I still call her Dr. Dooley because I'm not going to call her anything about that because she was my neuroanatomy professor at Logan. But she joined me a long time ago and she's joining me today on the podcast. So thanks again for coming on the show.
Oh, thank you so much for having me. Yes, you can call me Dr. Dooley as long as I can call you Dr. Beard. It's
deal.
Okay.
So let's jump in. We were kind of asking this before and it seems like it could probably go on forever. But what's new? Like, what's going on right now in life and then also professional life?
Yes. I am very happily married with two fur babies. My husband and I in the middle of the worst part of the pandemic, I would say from the New York perspective in 2020 moved to Boulder, Colorado. So we're enjoying a new terrain. I still go back and forth between a practice here in Colorado, which is mostly telehealth. And then my practice is in person and in telehealth in New York City. I'm still teaching for the four schools. Sophie Davis, NYU, Cornell, and Einstein Med, and I'm adjunct, of course, in order to have a clinical practice. And now I'm back live teaching courses in person for NKT, neurokinetic therapy, and we converted our ID courses to mostly online because one of our co-founders had her first baby. So pandemic baby for sure. Other than that, I'm about to launch a new. I've launched a couple of new courses since I talked to you last. A vestibular course, lymphatics course, and then this year I launched the Anatomy Angel Temporomandibular Joint course, TMJ course, and then I'm teaching for somatic senses, teaching a TMJ connection course. So this year is all about the jaw.
Wow. Very cool.
Yeah,
okay. So that's it. It's just a few things. Maybe we'll dive into time management skills a little bit later, but okay. So we have the four schools. We have the outside kind of modality or technique kind of stuff like NKT. Now the Anatomy Angel.
Yeah,
right?
these are short courses. Yeah, they're 5-hour short courses on topics that our ID courses are 15-hour anatomy courses with assessment and corrections. And so for people that can't dive into a 15-hour course but like one particular topic, people had suggested that I do certain topics. So I've done these 5-hour courses called Anatomy Angels, and it's a functional anatomy assessment strategy for things like pelvic floor, menopause, which I think is new since I talked to you last, lymphatics. And this year we add in temporomandibular joint as well.
Not that you weren't busy enough. So what spurred you to want to create? I'm assuming that you helped create the ID, kind of company and the whole movement there. So how did that evolution occur?
Yeah, for Immaculate Dissection, I'll just abbreviate it ID. I am the content generator for sure. The biggest thing that spawned it probably was my anatomy education obviously had these huge holes. Logan did a fantastic job of educating me with anatomy, fantastic instruction. It was more about how putting it into the body and making it more usable for me. That was my great struggle. So I got the master's degree in anatomy and wanted to teach. And that's a big part of it. I think my biggest struggle when I taught your class was that I was not currently doing a lot of practicing. I was doing acupuncture, but I wasn't really doing chiropractic. And it was really hard for me. I didn't go to chiropractic school for no reason. So I had to leave Logan in order to love teaching there, but I had to leave in order to be able to integrate the two. And as I was, practicing, I started to develop a niche and started to consult with other practitioners. And what ended up happening was I noticed that the biggest flaw that I saw in my colleagues, these incredible colleagues, was that they had a hard time also taking the anatomy and putting it into the patient, making it simple for themselves. With that said, I was like, well, why don't I do that for people? Why don't I put anatomy into a functional anatomy setting? And I'm not the first to do it. There are great series out there that do something very similar. I just have a certain way to do it that it seems to appeal to the crowd that it appeals to. And it's basically taking anatomy and putting you back in anatomy class after you're not getting graded on it, not taking a board exam on it, and putting it into the patient in a very functional way. The feedback I get is that it makes their assessment process easier. They have an easier time being able to get to the root of the problem faster. And that is what I want to do in life, is help not only my patients, but my colleagues that are driven and magnetized towards this incredible set of professions and health professions get to their results faster so they're less frustrated and confused.
Well, I have two questions on this. I'm going to pose them both so I don't forget, but we can
Yeah,
tackle one at a time.
sure,
One would be, I know there's functional anatomy courses that are taught in school now, right?
sure. Yeah,
I think we still need traditional anatomy as it's taught, right? Whether it's
you
dry
can,
lab, wet
yeah,
lab,
yeah,
but
you
do you
can't
think that we
really.
need more connection and integration off the bat so it kind of makes it's more palatable and more understanding of like why you'd be using it rather than just taking the bare bones knowledge, like you said, like you had the knowledge, but you're like, I just don't
Yeah.
know what I'm doing with this. Do you think a lot of people are falling into that same trap and it kind of makes people
Mhm.
maybe less not interested, but just they don't gravitate towards learning it as much as they should probably?
I guess the feedback I get, I have I work really hard to get strong evaluations with my students at the 4 schools I teach for, right? The reason I still teach gross anatomy is because it's the only way to make functional anatomy make full sense. There's no way to do it other than that. So at most of the medical schools, the way that they teach, and some chiropractic schools, some other health profession schools, you learn anatomy at the same time you're learning histology, at the same time you're learning pathology. You're doing them all concurrently so that you can understand an assessment better with the root of why you're assessing what you're assessing. That was missing for me in my curriculum. It wasn't designed that way. I had to take anatomy and then maybe functional anatomy later on as an elective or something. And that's fine to do it that way. It's just you have to make sure you have both. You neither exist without each other.
So can you give, maybe this is hard to draw out of nothing, but probably not with you being an instructor. What's an example of this? Like where,
Mhm.
and like taking the bare bones anatomy, plugging into a functional anatomy model really pays dividends for assessment and maybe a treatment outcome. Is there any specific
Yeah,
thing you can think of?
I could absolutely help you with this. So if I'm teaching core stabilization, which is a hot button topic, everyone wants to talk about core. The first question I'll ask the class is, what is the core? And they get stifled. They won't be able to tell me what it is. They just know it's important. They're like, oh, stabilization, they'll say proximal stability for distal mobility because they heard Greg Cook say it. And I'm like, you're exactly right. But why? Why does it create stability? And then I'll just be that annoying 2-year-old saying, why? And they'll come down to the fact that they can't relay the gross anatomical placement of the structures with a functional assessment. So what we do in ID is we say, okay, I'm going to teach you the transversus abdominis. I'm going to teach you multifidus lumborum, and then we're going to put it into a functional assessment. And it's immediate. It's that same day. It's that same course. If you don't make it functional at the same time that you're learning the structural, I think that there's this lag time where you forget the functional anatomy and then you have to relearn it or the structural anatomy and then you have to relearn it anyway. So that's what ideas, what I'm so proud to teach for that course and have proud to be a co-creator, is because it's doing exactly what the kind of anatomy class that I needed for functional anatomy, where the structural was still imperative to learn, but you immediately went into the functional assessment of it. So if I'm teaching transversus abdominis and diaphragm relationships, and then I put the patient in supine 90-90 and I say, hey, class, let's assess this person to see if they have a strong quality antagonistic relationship on breathing with diaphragm and TBA. And if there's not, how do we help to optimize them? Well, let's palpate. So let's teach you how to palpate with the anatomy. Knowing where the anatomical location is of course crucial to palpation. And then let's see if this tissue quality changes with cueing. And the feedback that we often get from ID is like, oh, that's the anatomy class I've always wanted. Like for it to actually be usable immediately, and the immediate integration that you don't have to go home and study it for 20 hours before it's usable. No, Dooley has this flow chart that you do this step, this step, this step, this step. And now that I know the anatomy, I understand what the heck I'm assessing, and I'm not just parroting Dooley.
Which, dear God, me getting into teaching courses, how much do people love a checklist?
They do.
I mean,
And
if
I
you can give
listen.
them a process, I mean,
Mm-hmm.
it helps.
You have to give them a standard operating system. That's what we all need. We all need. I mean, I fly a lot. I'm going to fly 6 times this week. And when I walk onto a plane, I listen to the pilots talking to each other, and they're doing their standard operating system. And I'm not a great flyer. I fly out of necessity. And when I sit down at my seat, I feel more comforted knowing that they've gone through this checklist. I feel immediately safer than if they hadn't, if they were just flying by the seat of their pants, right? So we should all be like pilots. We should all have a standard operating system. It keeps us calm. It keeps us from making mistakes, human error, and it gives the patient the best total, just quality chance at a full assessment, with most of the primary problems being at the forefront. If you have that standard operating system, I mean, students do love it. You're exactly right. They love it for a reason, because it works.
So I don't know if you'll agree with me on this or not. What I've seen from a lot of my mentors, and I would include you in that group, is, these aren't people that had a course like yours. Like it wasn't there. But people that are really good clinicians have a command of the anatomy, whether because they put the effort in, right? They just spent, 4 times as much time in the lab as other people, or they just have this, very good memory, photographic memory for, nerve innervation, supply, all these things. And then you see them draw on that in practice, where me just being in practice for a short time, I've seen students and interns all bring up, I mean, even just a anatomical structure, not, derivation of a nerve, and then they're like, really? And you're like, well, if you didn't, like, you can just see, like, if you didn't know that, how would you even get to, A plus B
Yeah.
equals C? But like, would you agree that you just see people that have like that command, however they got there, right, on purpose
Oh,
or by
yeah.
default, just tend to be
Mm-hmm.
better clinicians?
I think that we're all going to meet in the same, like you could take different GPSs to the same location. We're all going to get to the same location through trial and error, or through study, or through a little bit of both. Like you're a brainiac just like I am. We're going to be very cerebral about it, but we're also going to see what the patient responds to, and then start to develop an empirical data system of what actually works for people, especially in certain populations or certain sports or your certain body parts even. So I think you are completely accurate that one of the best assessors I've ever seen is Dr. Chris Kirby. He was one of my classmates in chiropractic school at Logan. He sat right behind me. So we developed, of course, a keen friendship. And he teaches for us in ID. And I also teach with him in NKT. He's a superior instructor. He's completely different than I am in the way that he gets to the spot initially. Not now. We both do DNS. We both do NKT. We both do ID. We treat a lot of people the same. And of course, we both do chiropractic and acupuncture. But the way that he would get to a spot was different before. And I would ask him how he would get there. And he would say, well, I use my photographic memory. I don't have a photographic memory. So he would rely on that. It used to drive me crazy in school. I'm like, Chris, how do you remember that? He's like, I just see it. And then he would ask me, like, how do you get there? And I was like, well, I feel it, or I, watch it. And I think what's great about surrounding yourself with these exemplary professionals is learning how they get to a spot, but we all kind of have this common ground. And I'm really into teaching the common ground. My big goal is to make anatomy matter, obviously, which is what we talked about at the first podcast, but then also to make it very easy for people, which people tend to struggle with. And having
Mhm.
studied it since I was 24 and I'm 43 now, 18 years later, I'm still learning every day, but I don't feel crippled by the depth of it, because I know now that making it simpler has always been the goal. And what I attempt to do is make it simpler so that people that don't have this kind of natural affinity towards it, or don't have a photographic memory, people that really struggle to assess, uh, they have a standard operating system that's simpler. And then I can always make it more complicated for them. I can always talk to them about embryo. I can talk to them about all of it. But most of the time, people don't want that. There's usually 1% of the class that wants me to go into more depth about something. And I'll usually say, is everybody else interested in that? And I'll see the shakes of the head. And I'm like, okay, can I talk to you about that on a break? And then I'll
Mhm.
single them out and let them talk about it. Or maybe we'll talk about it online. And then I'll see the likes come in and I'm like, oh, okay, people are really interested in that. But for the most part, I think that you're right. We're all going to have an adaptation to working with a patient and trying to get the best results the fastest. And that's all I care about, is trying to help other practitioners, including myself, get the results faster by any means necessary.
So when you're developing this, SOP or checklist manifesto for ID, or,
Mhm.
just how you attack practice, what are some of your first principles, or, just pillars that you're, using to calibrate this? Because it can't just be
Mhm.
like, well, I picked this because this is like, how do you go about that process of like, what is most important? Where do you
Mhm.
start?
Yeah, it's a great question. So there we have 6 ID courses that are 15 hours each, right? And then we have 4 anatomy angels that are 5 hours each. And so in 10 courses, I tell people with these flow charts, with these standard operating system flow charts, the most important thing is to clear core stabilization of the center of mass. Because if you don't have and I'm not talking perfect symmetry. I'm talking about generalized symmetry on either side of the center of mass between L4 and S1. For people that don't know anatomy, this is basically where your belt comes around you, right? Uh, and if you don't have that, a fairly optimized, generally symmetrical stabilization around this area, then the body will develop either successful or poor compensatory strategies in order to enable a semblance of assisted stability. And in that case, why not peel the onion off first by trying to get them as stable as you can on that visit, centrating the lumbosacral joint stabilization first, and then start to move into the periphery. So I would say our first rule on the flow chart is clear the core. You'll see it on every single one of our flow charts. We have 6 ID courses and 5 flow charts. One of them is a nerve course, so not a direct. It's more of a neurological exam rather than a flow chart. But the other one's flow charts, and people love flow charts. They love that standard
Mhm.
operating system. I follow this line and I get to here. The whole course is about understanding what the flowchart means. So, but they can put the flowchart up in their office, and every single one of those 5 is clear the core first. And I understand other people do clear the eyes first. Some people clear the feet first. Some people think the hands because it takes up more of a somatotopic map on the brain for proprioception. I hear their arguments on all of it, and I don't think anybody's wrong. But we have found the most success with ID is getting someone more stable in the middle so their limbs can develop a clear line towards proprioception. So I would say core first.
Is there, knowing the way a little bit how your mind works, is there anything more in depth that led you there? So I know a lot of that's probably experience, right?
Yeah.
But I know that some of the methodologies that you and I, have been schooled in would also kind of start there. But is
Mm.
that like, some people would clear the eyes, and then they may have an argument for that. Like
Yep.
besides just saying what frees up, the periphery, is there anything that you're like, man, from a neurologic standpoint or ontogenesis or whatever it is, that you're like,
Hmm.
yeah, that's kind of why we went there too, not just like what we thought was important just because?
Yeah, it's a great question. I mean, honestly, I think that our intrinsic homeostasis, limbic level homeostasis of balance, whether it's partial pressures of oxygen, pH levels, satiety levels, temperature levels, all of it is hypothalamically managed, right? Hypothalamus to pituitary, pituitary out to the center of the body. And so I compare it to like the hypothalamus being the owner of a team and the pituitary being the coach of the players, and the players being all these hormones and everything that's kind of dictated. So I think that in order to create a semblance of that that line, the anatomic line, I don't want any torque. I don't want any torque along this midline of 7 diaphragms, the first of which is the hypothalamus, right? With the pituitary axis, diaphragm ocelli, this little connective tissue that covers the pituitary. If there's torque on that, there is definitely a problem, obviously. But it's really center line. I think about center line, that diaphragm, the soft palate for our nasal breathing, the floor of the mouth for our oral breathing, the 4th diaphragm, superior thoracic aperture, for us to get limb or artery supply and nerve supply. Our 5th diaphragm, obviously a breathing mechanism, thoracic diaphragm. Our 6th diaphragm, pelvic floor. Our 7th, the urogenital diaphragm, which is helping us, of course, procreate, and then also to help us take things in and out. I think that that central line is crucial. And the majority of my patients, I do find that when I start to perturb their system and ask them in their history and really listen to them, that things start pretty close to the middle. to the rib cage. Makes a lot of sense when you think about the fact that, 25,000 breaths per day are under that demand. And if it's suboptimized, then we're going to create compensatory strategies around it. I also think that my empirical data certainly does support that. But I know that the thoracic diaphragm, is the only muscle in the body I can think of, and correct me if I'm wrong if you can find it, audience, but it's the only one that's viscerally innervated and somatically innervated directly. Like the thoracic diaphragm is part from the dorsal mesentery. So embryonically, it's gut, which is why it controls the esophageal sphincter on the lower aspect. It's not a true sphincter, but you get my drift. And I don't know, like food's important, air is important, and they're the ways we get energy. So I do think that central axis of stability is really, really crucial. I'm not saying the lateral systems of movement, the oblique systems of movement aren't crucial. Of course they are, but I mean, I'm not a crab. I don't walk sideways. I walk forward. You're a runner. You run forward for the most part. And I think that if we ignore that sagittal central plane of stabilization of mass and start to treat the peripheral stuff, it's going to lead us back to the center anyway. And that's the mistakes I used to make. I would see an Achilles tendinopathy and treat the Achilles. And I'm like, now it's more like, I have Achilles tendinopathy. This is a part of my assessment for a line of structures, including the core, including multifidus and lumbar erectors on that side. Because I know that they're part of a subsystem of movement. And if the person can access that subsystem, they're going to overpush with their calf, which happens to most of my Ironman athletes. They'll get a calf tear and then just keep treating the calf, and then they end up in my office and I'm talking about their core and talking about their pelvic stabilization, and then telling them to not use this secondary synergist to push off, that they should be pushing off with the entire system and not just their calf. And they're like, what are you talking about? I guess the first time they've heard it and they're an elite athlete. And I'm like, well, and then when we start to get results, then the buy-in is huge, and then all the Ironman athletes are coming to see you. And I think maybe that patient outcome has pushed me towards understanding that system of, don't negate the core even in a distal problem. Don't negate the connection. Treat it all 100%. Don't just treat their lumbar stabilization. If they have Achilles tendinopathy, you're going to do TNT on their Achilles. You're going to do stuff for their Achilles also, but don't expect you doing Graston for an hour on their Achilles to changing their run, especially if there's a systematic problem along a line of tissues, especially that involves lumbar stabilization.
Well, comment and then a question on that. I think it's really important, especially for students and even new docs, to hear somebody that's been in the game at various, aspects of the game, teaching, clinician, to go through the thought process of why you're doing stuff rather than taking a methodology that you've been taught and just applying it. That's one of the, in my opinion, one of the biggest mistakes is that people just do as they're taught. They lose the ability to kind of break down concepts because they don't learn basically the basics of science, right? Anatomy, physiology, biomechanics, physics, and then they kind of lose sight of that, and then they have nothing to test anything against. So it's like, well, I'm doing this because I have results, but then could you backwards? Yeah, I got a result, but like, why would it have worked? Which then you're not learning. You're just like, well, I had a positive outcome. Well, I'm going to do that next time. Well, it may not work next time, and you can't work backwards. So I see a lot of that. My kind of question would be, there's a lot of specifics in there, right? You're breaking down like diaphragmatic systems, you're breaking down neurology. How specific do you see yourself getting in treatment? And there's a lot of ways to go with this. I'll expound a little bit. So we live in a time where people are largely unhealthy. Even that Ironman athlete may not be healthy. They may be fit, but may not healthy.
That's true.
How often do you see yourself going really specific versus general to have bigger outcomes, which I know we need both, but does that question make sense? Where like, do I need to go into, the 7 diaphragms and man, like your pelvic floor is off. I know you got a calf issue, or like, dude, you're not sleeping enough. I don't care how well your pelvic floor works,
Yeah, those things are not separate to me. The way I describe things to my patients and my students is that, imagine that 3 people are holding up a couch, and one of them is biomechanics, one of them is chemoreception, one of them is thermoreception. Those are the 3 things that really mitigate pain perception. Even if something is torn, some people don't feel a tear. What's the difference between someone who feels a tear and someone who doesn't? A lot of it is their inflammatory cascade and their ability to temper the nociceptive system, right? So if the biomechanical part is not picking up its part of the couch, then you have to really fix that. I mean, chiropractic is great at chiropractic rehabilitation, especially is great at that. Physiotherapy is great at that. Personal training is great at that. Then you have this person that's the biomechanics are you get that fixed and it's holding up, but the couch is still falling on one side because they're not sleeping, because they're eating crap, they're not recovering well, they're under eating or overtraining or however you want to see it. That they're not assessing the systemic portions of it, and that's a problem. And is this person affected by baroreception and and thermoreception? Like that one to me is a lesser factor, but for some people it is. Like I have joint pain when it rains, or when I go into a hot climate versus a cold climate, my pain can come out. I feel like that's the middle person on the couch that doesn't really do as much, but they're still
Mm-hmm.
important. But the two people on the ends, the chemoreception and biomechanics, that's what you're talking about. You're talking about, I could do all these corrective strategies, but if I'm not going to change my very, very stressful situation, then expect me to be hypersensitized towards an inflammatory cascade and thus more pain afferents. And I'm very proud to be a chiropractor. I'm very proud to be a chiropractor because I feel like the chiropractic profession does one thing really well, and that's being holistic.
Mm-hmm.
And I love physical therapists. I train physical therapists with some of my techniques. They're wonderful, but I ask them about recovery management, sleep management. If I had a conversation with them about sleep bruxism, they would not even know anything I'm talking about. If I go to a chiropractor and they're like, oh, have you looked at their nutrition? Have you looked at their diet? It's just a little bit more prominent in our profession because it's a little bit more holistic. I believe in a holistic clinical practice. I have some people where I'm running labs and neuro labs and looking at their sleep, and I'm only looking at that because they have another chiropractor or another rehab specialist that they're doing, all of the rehab with. And people will come to me and say, well, I'm not getting anywhere with it. I'm like, that doesn't make it
Mm-hmm.
bad rehab. It just means it's ill-directed, that you're working on the biomechanics part of the couch and you need to work on the chemoreception part. And I'm sometimes the first person they've ever had that conversation with. And that has to change. And that spawned the anatomy angels. The anatomy angels don't cover like as much biomechanics and gross anatomy. They cover, hey, how this anatomy is affected by the chemical cascade.
Mm-hmm.
And they've grown in popularity not only because they're short, I think, but because you don't often hear a lot of, at least in curricular education, like you don't hear a 5-hour lecture on the lymphatics or a 5-hour lecture on menopause. We probably got maybe a half an hour to an hour on those in school for our profession. And then after that, unless you studied it on your own, you may not be really integrating it in. And so I do the hard homework for people so they can save a lot of hours and then say, here's the references in case you want to look them up. But this is some things to try with your clients. And then often my patients sometimes take those courses because they're like, I can't believe that stuff worked, Dooley. I can't believe you had me increased my sodium and all of a sudden my recovery enhanced. And I'm like, well, did you think salt was bad? Who told you it was bad? And I think you're right that the critical thinking part of it, like I'm a critical thinker, you're a critical thinker, and people are going to rely on us to help them critically think because it's so easy to parrot. Well, Dooley said this or Beard said this, and then you ask why. Like be the annoying 2-year-old. Ask why you think the way that you think, or would you be able to describe it to a patient if it's weird? Like
Mm-hmm.
pelvic floor to the Achilles connection is a good example. Like what the heck does my pelvic floor have to do with my Achilles? Actually, a lot. So I think that a holistic approach has to be, you have to build a trust with a patient first, obviously. So that first visit is really, really crucial. All of my visits are 45 minutes. And the reason why is that they can't take in more of Dooley. 45 minutes of Dooley is just a lot. And so it used to be like an hour for new patients and then 45 for repeating. But I'm like, no, like just tiptoe them in
Yeah.
and require 2 appointments. And I found that to be very successful. And then you can start with the biomechanics on that first visit. And if they're not really getting the results in 2 to 4 weeks that you would like, then you're not getting a 20% reduction of chief complaint in 2 weeks of doing corrective strategy. Then you have to start to think, is this the only thing?
Mm-hmm.
Or do I need to talk to them a little bit more about their sleep or their smoking or their diet or their stress level or their relationships? And that's why I love co-caring and building a good referral system.
I couldn't agree more. I mean, whenever I'm teaching now, a big part of what I think I'll teach more of in the future too is that, I mean, we are deemed as, a primary portal of entry in most
Mm-hmm.
states. And
Yep.
that is a huge responsibility. And if you're
Mm-hmm.
going to own that title, like you need to own it, you have to be a physician, right? You have to be a
Yep.
physician first, not just a rehab specialist, not just strength conditioning specialist,
Mm-hmm.
not just adjust everybody. And that's taking the whole picture in. And in my opinion, I mean, it's already happening, but a decade from now, all of the things that we do from a manual therapy biomechanic standpoint, I think are going to be less effective because the systemic health of people is getting worse, which
Yep.
means that those other arms that are holding the couch up are working harder,
Yep.
right? Or not doing their job as well, however you want to look at it. And I really think that we're going to have to get a lot more holistic in our approaches and a lot smarter of how we treat an Achilles tendinopathy in that
Yeah.
same athlete a decade from now. And I think that's just, courses like yours and, it's hard to teach critical thinking. I mean, that's like,
Yeah.
is that a
Yeah.
skill or is that a teachable
Yeah.
skill? I mean, I don't know.
Mhm. I think that you just
But
have to encourage it. I mean, I'll
yeah,
sometimes like I will like stymie people sometimes asking them to think. Like I'll have a class in complete silence with this petrified look, and I'm not grading them at ID and NKT. I'm just asking them, why do you think the way you think? And almost always they won't answer because they're afraid it's going to be wrong. And I'm like, we've got to let you critically think because eh, there are people that don't fit the mold, or they're not. You have to determine whether or not, if you're not comfortable dealing with the chemoreceptive part, then you got to build a referral base so that you look good. Because you're right, as health starts to get poor, sleep starts to get deprioritized, social media is starting to change our brains, all of these things start to happen, we're going to find less and less effectiveness in just a touch therapy or a couple of corrective strategies. Hip cars can only get you so far if you can't even recover from your workouts or sleep.
so on that topic, is there anything that you're adding into your quiver for treatment or thought processes or want to in the future?
Um, the biggest part of me, like in Colorado, I have a little bit more leniency and being able to do more. I'm trained acupuncturist, but I can't do acupuncture in New York because I never finished the NCCAOM stuff because my practice got too busy. And I'm much more able in Colorado to think more about what I can do. I can order more. I can do IVs. I can do a lot more stuff. And I see myself moving towards including more prolotherapy, including more uh, of the regenerative medicine, of the holistics. Lately, the big talks is all on recovery. Like I'm trying
Mm-hmm.
to get my patients to stop thinking that salt is bad, or that um, a big thing is that a lot of them are intermittent fasting, and I have to make sure that they know if that's going to benefit them, if they can track it well. Or are they just doing it because it's a fad, or are they actually seeing changes on their blood work, changes in their recovery, changes in their sleep, changes in their soreness, change, like all of it. And so the big thing I'm kind of pointing myself to now is understanding more of the blood work and more of the urinalysis. And we got that education at Logan. We got a basic education of those things. I'm very
Mm-hmm.
proud to have known as much as I did know graduating, but now it's the deep dive of, just because my sodium is elevated on my urinalysis or my blood work does not mean that I'm not dehydrated, because I might
Mm-hmm.
be pulling from the cellular salt and moving it into my serum. So I could be chronically dehydrated and actually show up within normal limits. It's more about understanding and this is critical thinking again, understanding the blood work, challenging what I'm reading in research, because you have a mountain of research on sodium saying it's naughty for hypertension. And I'm wondering, like, wait a minute, the Chinese medicine part of me says that salt is softening. It softens the encourages elasticity of blood vessels. And I'm like, wait a minute, that doesn't make any sense. And so as you start to like do the deep dive, I want to understand actually what I'm actually seeing, and not just be ICH, ICL on blood work.
Mm-hmm.
And so that's what I'm doing currently is I'm really starting to do a lot of cross-referencing, trying to understand people, starting to follow people that are real critical thinkers that think outside the box, like John DeNicola Antonio is a great
Mm-hmm.
example. Gosh, that has really gone under fire and just gave people the C7 dermatome when they didn't agree with them. He was just like, I don't care what it says in a litany of literature. I'm a researcher, and I'm telling you, you don't understand research if you think that this is right. And I'm trying to find myself following more of those people that are willing to think outside the box a little bit and look at blood work a little bit differently, look at urinalysis a little bit differently. So the deep dive into these very big biomarkers is where my
Mm-hmm.
practice is heading.
Today's episode of the Anthro Education Podcast is brought to you by The Age of Movement by yours truly. Subtitle: Time Keeps on Moving and So Should You. The Age of Movement it's a short read. It's aimed at Gen Pop, and it is a look at the health conundrum we're in and what aspect or role movement plays in that. The middle of the book is a guide of movement from utero all the way to death, broken into sections of what's expected, what's normal, and some tips on what you can do to improve your movement and overall health. And then the last portion is just my opinion on where we're going and what our relationship with movement needs to be to have better outcomes in the future. So again, The Age of Movement, available on Amazon, also available on Audible. Go check it out. When precision medicine is definitely, whether you want to say it's the future of healthcare, I mean, it's definitely going to be a big part of healthcare, however
Mhm.
that, evolves. But what I find myself telling patients that all the time is our population pooling for pathologic norms for lab values are from an unhealthy population. And that's why every
Yes.
lab company has different values. So then you have to kind of look at things honestly in that, cliche n equals one account and say,
Mhm.
like, I mean, that's precision medicine, right? Looking at genetics,
Yeah.
looking at your scenario, putting the blood work into it, and then kind of seeing this stuff. But people get very wrapped up in, this is off, so I do this, right? I take this
Yeah.
supplement, I remove this, I take this medication. It's like, this is a human is a complex yeah, it's a complex system. So a system of systems, one thing has an effect on maybe 10 others and vice versa. And
Hmm.
that's, I mean, it can be daunting, like you said, just anatomy itself. So take
Yep.
one system or a bunch of systems, but look at it as anatomy and you're like, oh my God, it's just, it's looking at the ocean. Then you add
Yeah.
everything else into it. You're like, well, I'm looking at all the oceans in the universe. And it's like, well, what do? You,
Yeah.
you get better at critical thinking. So you pick the one or two biggest things to work on with that person and really go after it versus thinking I have to do all these things and understand everything.
Yeah.
That's tough. That's not easy, but
Yeah. This is
is
a
there
very
a
tough
oh,
thing.
go
It's a
ahead.
very tough thing. I think that my patients are always floored when I work with them on patient responsibility, because as you can imagine, I don't let people get off easy about anything. But I'm kind, and I'm not mean about it. I think it's ultimately kind to make people responsible. So I tell them, did your doctor raise your blood pressure medication? Yes, but your blood pressure medication is there's just a slight change in the systolic and not diastole. And American Medical Association says that you have to have a certain, raise in diastole in order for them to raise the pressure. So are you holding them accountable? I don't even know what you're talking about right now, Dooley. And like, well, this is part of the thing. If you're going to take medication, you need to understand what it's doing. And in like, I had a patient a couple of days ago that had her blood pressure is within normal limits, but her glomerular filtration rate of her kidney is low, and they have her on a low sodium diet. And I said, well, you're taking a diuretic. You're you're
Hmm.
you're losing a lot of potassium and sodium, and that's why you feel this low in energy. And rather than getting on a new medication, can you talk with your doctor about changing your diet electrolyte intake, because your GFR is showing that your kidneys under duress, and kidneys like more electrolytes. They don't like to have a decreased amount of them. And she was like, I think that's going to go over really poorly, because they tell me, and I go, it might, but you have to start to have advocacy for self. I have almost left my clinical practice a number of times to start a patient advocacy group, just to be able to go into the office and be and debate with the doctor on whether or not this is the greatest plan. The greatest example I can give you is my own mother. My mother had a stroke and arteriovenous malformation, genetic congenital deformity, blood vessels in the brain. When I was 21, she was 50, right? And I didn't know anything back then, but now I know stuff. And she was having pulsatile tinnitus, this scary type of
Hmm.
tinnitus that doesn't go away. It gets much worse when you lay down. And I was very nervous for her. And being the overprotective child of my mother, I said, or can you go back to your neurosurgeon? We need to do a follow-up, and we need to get a CT angiogram. We need to see if you have another type of congenital anomaly in the blood vessel string. She was declined that. And I said, go back, and here's the script. And I told her exactly what to say. And I made sure to add that if they didn't order it and that something did go wrong, that this neurosurgeon would be responsible. And all of a sudden it got ordered.
Hmm.
And I'm like, you know what? I shouldn't have to bully you with the anatomy of what's happening, or bully you with a malpractice suit in order for you to order a study that needed to be done anyway. And it is part of an AMA protocol for if someone has pulsatile tinnitus and a history of aneurysm or stroke to do a CT angiogram. And like, why do I have to hold you accountable to your own principles that you took under oath. I shouldn't have to do that. So I implore your audience to study harder and do more, because if you assume that people are getting that kind of precision medicine just because they're getting functional medicine blood work done,
Hmm.
they're probably not. And if you want to, it is a burden, it is a lot of responsibility for you to have to study this stuff. I get it, okay, but doctor means teacher, not fix people. It's your responsibility to hold them accountable for their own health, and encourage them to learn more about it. And the results I get with that are really, really good. And the people that don't like it don't come back, and I'm not sorry about it, and I don't
Hmm.
lose any sleep. They don't decrease my recovery. My sleep is fine. So I think that if I could give any like piece of advice on that, regarding that precision medicine, would be start with you.
Hmm.
Like just get a little bit better at understanding something. Like look at your patient's files. If someone has a problem with SI joints, I won't call it dysfunction, but SI joint provocation. If they have SI joint provocation, have you cleared them for connective tissue disorder? Because Lord knows nobody else has. Are you looking at not only their positioning and sleep and all those things that you're probably already doing, but look at the connective tissue itself. Like, does this person have a diet that supports recovery? Do they sleep? Do they have have they run a genetic panel to look for these
Hmm.
things? I think it is a really crucial thing to do.
And I don't know about you, but that's the fun part of practice for me.
Oh
Like
my
if I
God, it's
just
a
had to go in and
blast.
just do the biomechanics part, I don't think I'd last. And I've
Yeah.
honestly thought numerous times about going down to there's VCOM, the Auburn School of Osteopathy, just to
Hmm.
expand my scope, which is unrealistic due to time and family and all those other
Right.
things. But I'm just like, every once in a while, you're like, dear God, like you said, like it just doesn't exist at the level that it
Hmm.
needs to. The people that are really good around us, I mean, they don't even accept new patients anymore because they're just
Yes.
overwhelmed with the amount of people that are looking for them.
Yeah.
And I have my own mother advocacy story that's just, it baffled me. My mom has dealt with respiratory issues her whole life, right? Diagnosed as asthma and, severe asthma to all these different things, tried every medication under the sun. Um, so I was home. I think it's like 4 years ago. We're home for the summer. She happens to have a pulmonology appointment because they put her on a corticosteroid that was she sounded like Marge Simpson. She had
Mm.
raspiness and she's like, I can't do this. She goes, my symptoms are somewhat better, but like I can't talk. Like if I talk for more than an hour, I lose my voice.
Mm.
So I had a visit and I'm just kind of talking to her about, well, how do these visits usually go? Well, they base everything off of FEV1, right? Blow into this
Right.
tube and just kind of see where you're at. It's never been good from day one. We're
Mm.
talking 30 years. It's never improved with medication. So I don't get paid for those cases. Like if
Right.
somebody fails, eventually they leave, but that's a different topic. So then I was like, well, let's just
Yep.
do some like breath work, some breath holding work, see what happens. Breath hold, triples. FEV1 goes through the roof, just functional stuff. Then I go, hey, can I just come to your visit? And she goes, you can't talk. You just have to stay there. Well, I could go far into the details, but the saddest part of this was she goes in, the physician was about my age, very nice woman. And my mom tells her what's going on. And she says, well, we're going to have to change your diagnosis from asthma to COPD to try a different medication, which I thought was just,
What?
eh. Then she literally opens the cabinet door and it looked like a laminated Chinese menu. There were pictures of like 15 different medications, the picture of the inhaler or whatever it was. And
Hmm.
she literally goes, oh, we've done that. We've done that. We've used this. Okay, we're going to do this one, and puts that in the file. And I go, well, what is that? She goes, well, it's a different form of inhaled corticosteroid. And I go, but is there an inflammatory component to this? And she goes, well, of course there is, because asthma inflammatory. I go, is it? And we kind of went on this one little tirade. And I could have taken that as far as, and she was kind of like, well, who are you? And I was like, I'm just her son or whatever. But very quickly you could realize, like, you can't arm your mother or your father or your best friend with all of the physiology and anatomy that you're armed with. But like
Yeah.
at some point, like you said, like it is your health,
Yeah.
and these things that some people are doing for their health detract, and they get on. My mom has massive osteoporosis due to years of these medications. Now has to take
Right.
it, IV infusions for that. And it's like, well, you've gotten yourself in a scenario where the best patient advocate in the world wouldn't be able to get you out of this. And
Right.
that's kind of where it gets sad. So it's like, I don't, that is on us. Like you said, it's a huge
Yeah.
responsibility, but like, who's going to do it if we're not?
I agree. All you can do is what you can do. I'm not trying to change everything about the world, but
Mm-hmm.
I am trying to change the world that I can change. I'm trying to optimize myself, which definitely does everybody good if I'm more optimized because I'm bringing to the world someone who's more optimized. And I am asking the hard questions, whether they like it or not, in a kind way, with a kind voice, with a huge hug in my voice. I'm asking them, look, I'm here for you. You have me on call. My patients know they can text me, they can call me. You have me to answer these questions. And some of the amazing cases that I've had where people have come out of the doldrums from, just be drowning in medications they don't understand, and they're not necessarily, the medicine's so specialized that the pulmonologist is not always talking to the endocrinologist, who's not talking to the rhenologist. And so it the patients left just like in in a storm. They're just caught in a storm, and they're just reaching out, but they don't even know where to reach. And
Mhm.
so it is really important to take responsibility for yourself and say, well, we have the Google machine, baby. You can look up a lot of the tests that ask for the tests that you're run, ask for the blood work, look into it, and then ask me questions because I'm educated about it. I can be your advocate if no one else will. And this is what has pushed my colleague Dr. Anna Folkmer, who's my co-founder for Immaculate Dissection with Danny Quirk. We talk about it all the time. We're like, should we like do practice like part-time, teach part-time, and then also take on patient advocacy? Because doing it one-on-one is enough for now. But as I get a little bit older, I'm in my 40s now, I'm like, man, should I have a bigger way to change the world? Should I change this more? I think it starts with the N=1. Start with the people that are in front of you, and then we have to. The only way to change medicine is demand the change. Well,
Mhm.
people are not getting results. I mean, they're not
Right.
changing their lifestyle. They're taking all these medications. I mean, statin is a great example. We watch people get on these statins and change their cholesterol and then become more prone towards diabetes, which wreaks havoc on the blood vessels. And when you look at the results for like statin as far as prevention of a primary heart attack, but if you never had one before, it's abysmal. Like
Mhm.
there is some data that supports it's better for someone who to have a second one, but we really don't know that to be true either. Like it's all this data fudging. And for me, it's kind of like, wait a minute. I know my father died of myocardial infarction. I know it was his second myocardial infarction. He smoked, he drank, he didn't exercise, he didn't have a purpose driven life, and he had incredible grief and sorrow from parts of his trauma life that were not worked out in cognitive behavioral therapy. So that all ended up with a 78-year-old male having a fatal heart attack. So now I'm like, I'm 43. That is, maybe some people would say that it's like 35-year difference, Kathy. You have 35. No, I don't have 35 years. I have right now to
Mhm.
start to, it takes that long to really peel the layers of optimization and understand this for myself. I don't believe that heart disease is, cholesterol based. I understand how people talk about with LDL and apolipoproteins, but when I get the blood work from the patients and I look at their lipid panels, I've only had one in 15 years of clinical practice that had an apolipoprotein list. And I'm like, well, LDL doesn't matter unless you only have like a high apolipoprotein B100. If the person still has quality HDL donors, then the person's fine. But then they're just put on a statin if their cholesterol is high. Like, this is erroneous. This is not only
Mhm.
bad medicine. This is harmful medicine. And if we don't advocate for our patients as chiropractors, as health practitioners of any kind, if we don't start to really help with this stuff, then we're just going to see these numbers rise, and it's going to be your parents, it's
Mhm.
going to be you, your family, that's going to be at risk. And start by living the example. Like, don't for me, I'm not interested in medication. I'm probably not going to do that. I'm probably going to do as much lifestyle until I absolutely have to take a medication. And like, you are your mother's evolution, right? You can only change as much as you can change, but you can learn from her experience and say, oh, I'm going to continue to do this breath holding stuff, and I'm going to continue to control my respiratory system, continue to run because I know it builds my cardiopulmonary capacity, and I'm going to be her evolution. That's the least I can do for her.
Well, I had this thought the other day of just and I posted about it, the difference between a healthcare practitioner or a practitioner of health. And most people are practitioner like a healthcare practitioner. That's fine,
Mhm.
right? I think we need way more practitioners of health
Yeah.
for a variety of reasons. Like you said, you're a more effective player within society at large. You're an example for the
Mhm.
people you're working with. You also understand things on a different level when you're testing things on yourself, whether that's exercise, diet,
Mhm.
supplementation, therapy, meditation.
Mhm.
But I think we have too many people parroting things that they're not willing to do, parroting
Mhm.
things that they haven't critically thought about. And then just like it's like a limbing off a cliff. Like you run into like a thought, like cliff diving experiment. Like I can't go
Mhm.
any further with a patient just because I literally run out of space. Like I don't have the
Yeah.
bandwidth based on like not knowledge. Like we all got the same classic teaching, but then it's that
Mhm.
thought process continues. And I think that that is largely just like what motivates you to keep
Yeah.
learning. Or, in my case, I don't know what drives you to keep going at the level you do. I feel like you're, 20-fold ahead of me, but it's like I feel
Mhm.
complicit if somebody's in my office and I know they have all these other things that aren't biomechanical or anatomical in nature, and I kind of know, but I don't know enough to help.
Yep.
Well, then the next person that comes in, that can't be an issue. Like it can't be. Like I literally know
Yeah.
enough to know it's a problem.
Yeah. I think the first step, that's a really important thing, is knowing what you don't know, admitting it, and doing two things: finding someone that does, that you can co-care with, and getting better at knowing. And that drives my entire career. Like, you asked me 5 years ago if I knew as much about blood work as I do now, and I wouldn't be able to tell you that. But now I can have a conversation on a phone with a hematologist and really ask difficult questions. And they're like, "Who are you again? Like, you're a why do you know this?" And I'm like, "Because I might be a chiropractor, but I don't fit into this box.
Mm-hmm.
I maybe can't tell, I maybe can't order a particular blood work because it's not in my scope of practice, but I can encourage them to ask their GP and tell them exactly why they want it." And it's going to be hard to argue with the patient that comes in with self-advocacy. And
Mm-hmm.
I think that I know I'm going to be studying this stuff for the rest of my life. I have no resistance towards that. My husband always says the difference between the master and the student is the resistance to the work. Everybody does the same work. Masters do the same amount of work. People call me a master of anatomy. Like, I study anatomy way as much, if not more, than you do. At another person does at a I don't know, community college level, whatever. I am going to continue to study. I'm going to continue to study the hemodynamics. I'm going to continue to study all this stuff so I can give better advice, that I can help people that come to me and say, "Hey, she's a chiropractor." That the way that my practice is completely word of mouth, right? I don't do advertising.
Mm-hmm.
So a patient will come to me and say, I go, "What did you hear about what I do?" And they say, "Well, they say that you just do a little bit of everything." It's music to my ears, because there's
Mm-hmm.
no like expectation that I have to adjust them if I don't feel the adjustment will even hold. Or I know that that visit's going to be 45 minutes of us talking about their blood work, versus another patient came to me and it was 45 minutes talking about how her symptoms raise when she, you has a memory of her sexual trauma. I'm like, "I'm not a CBT. I'm not gonna. I want you to go to psychotherapeutics for someone who's trained in that. I just want you to know that you're not crazy.
Mm-hmm.
You are raising up, or dropping the end of the couch, right? So you can do all of this PT, you can do all this corrective strategy and biomechanics, get all this manual therapy." I go, "Do you ever get a massage and the tightness comes back 2 days later?" And the same patient was like, "That happens to me all the time." She's like, "I spend like $300 a month on massage." And I go, "These aren't bad massages. I'm sure that massage therapist is
Right.
amazing at what they do. But if you are chemically, regenerating tension due to all of these chemical factors, interleukins, all these things, then, I'm not saying your money is wasted. It's just going to be a limited. You need to
Mm-hmm.
manage your expectations based upon that chemical reception." And all of a sudden they switch off and say, "Well, what can I do to help with the chemical stuff?" They open the door right for me. I don't even have to convince
Right.
them. And I just ask them questions of things they're already doing. So your audience can certainly do that. Like, if they're not holding their adjustments, they're not holding their massages, ask them, "Are you interested in maybe holding these better? Or if you pay for massage, making that massage last you longer?" "Yeah, what do I do for that, doc?" There's your open door.
I like that.
Yeah,
I think you're kind of doing what Brett Winchester talks about. He's like, I'm trying to blow the doors off of what a chiropractor could be, like just
it's
completely
amazing.
like reformulate what people think it is. And, that's going to be different for every practitioner. Like, not
Yep.
everybody has to be the same. I can
Yep.
remember the first time somebody came into my office and, they sat down and I was like, "Hey, what's going on?" "Oh, I'm here to just get healthy. Like, I've heard that you can help people." And I was like, I literally was thrown off guard. I was like, "Yeah, is like anything bothering you?" "Well, yeah, like kind of, but I just want to get healthy." I was like, "Oh, okay, here we go." Which is
Oh,
cool that
amazing.
like first time that you're just like, "Oh." but that I felt like that was me doing my job of like, okay, I've opened up the door for all these other patients enough to where they're like, hey, it's not just go in and get your ankle fixed or whatever it is. It's like, hey,
Mhm.
this is like a healthcare practice. And I think we need more of that.
Yeah.
Um, talking about being a, you know, lifelong learner, I was kind of looking up the Mahatma Gandhi quote of live as if you were to die tomorrow, learn as if you were to live forever. Like that's kind of
Oh,
like
it's
maybe your
nice.
mantra.
Yeah,
What is
I
something
would
you've
consider that, yes. Yeah.
what is something you've learned here recently that has just completely like blown your mind or just like reinvigorated you? Like, is there anything in particular, like an area of study or something specific where you're
Mhm.
like, holy cow, like this is just crazy?
Yeah, I'm right now I'm in the autoimmune rabbit hole. I'm really trying to understand what the heck that means and why the ANA of blood work is so like hard to like it gets triggered and then it seems to stay triggered. I'm trying to understand that better and how it relates to not only, you know, inflammatory arthritis like rheumatoid arthritis and, you know, psoriatic arthritis, but also skin conditions and how these things aren't separate. I mean, psoriasis is a good example of, you know, someone can end up with the skin condition first and then psoriatic arthritis, or psoriatic arthritis and then the skin condition, or neither of both. It's fascinating. Like what the heck determines that? And so right now I'm trying to understand that because for a long time my husband and I were plant based, and I would still consider us to be plant based in a way, but then I started to really do the observation of some of my patients with joint pain and how they would respond really poorly to grain. They would
Hmm.
respond really poorly to oxalic acid foods like kale, which is so popular. And I was like, okay, well, can we take you off of those foods for a couple of weeks, maybe say 3 weeks, and do nothing else different, just to see if the variable changes. Continue to do your correctives, come to see me, do everything that you're normally doing, and to see that the shifts, those little subtle shifts of like, oh crap, that food may not be healthy for that person. And the Chinese medicine part of me is already thinks like that anyway, of like, look at the individual in front of you. Like you said, the N equals one. You know, they don't have condition names, they just have pattern names, right? And that part of me is always in the office. So yeah, right now I'm super obsessed with what the heck that means. What does autoimmunity mean? And it doesn't even have to go as far as lupus and some of these, you know, really bad neurological problems, but what do they have in common and what's separate? um I think that the more I hear myself talking with patients, the more I'm starting to recommend them follow an autoimmune protocol for a few weeks to see if it makes a difference. If it doesn't make a
Hmm.
difference, it's probably not their big kicker. Then we need to look at other things. But being brave enough to try something different, I feel like in the beginning of my career, I was just so stuck on this is how I was taught and this is what I should do. And now I'm more like, yo, that didn't work. Let's try something else. That's exactly what researchers do. And people love to hear about research. So I'm trying to think more like a researcher and treat my patients more like a researcher would treat a hypothesis.
I like that.
Mhm.
So we were talking about maybe the difference, even though it's a semantics based one of a healthcare practitioner, practitioner of health. So you saying you want to be kind of the example and optimize yourself for those around you. What
Mhm.
is one daily practice that you feel like trumps all, or that you wouldn't get rid of if you know you were forced to pick one thing?
Ooh, there's a couple of these days, but I mean, I did marry a breathing coach. So, you know, watching him too is fascinating because he studied with monks and um, uh, there's this hot, and I'm going to say something unpopular, okay?
Hmm.
And I hope it doesn't come off wrong, but there's a lot of talk about trauma and there's a lot of talk about cognitive behavioral therapy. And as someone who has experienced a lot of trauma in her childhood and went through cognitive behavioral therapy for those reasons, I was still left with no plan, right? On what to do when I felt uncomfortable. And I didn't feel, and I don't think it was the CBT, you know, the trained therapist's fault. I think that they can only do so much. They can lead me to the water, but I'm going to have to drink it. So, you know, I'll be in a situation where I can feel I get triggered by something and I don't want to be a slave to that. So I find myself doing my 510s or doing, you know, the breathing training. And I just don't think that I would have been able to evolve to the current place I'm in or where I want to be in the future without that consistency of that training. And luckily for us, it's very popular right now. to do breathing training. Wim
Hmm.
Hof and other amazing breathing specialists, Stig Sepranson, all these great breathing strategists are making it almost like a fad, which is
Hmm.
I don't usually buy into fads, but this is a good one.
Well, I like
This is
James Nestor's
oh
kind of insight in
breathe,
his book
yeah.
that about it seems like every 3,000 years, breathing becomes faddish. It's like this revelation of research. And he goes, no, it's like
Yay.
it just keeps happening every 3,000 years or so in history because we realize it's important. We just forget about it for whatever reason.
Yeah. It's like it's the free thing that you can do. And that's
Hmm.
what I tell patients. I'm like, you can either I quote my husband all the time. He's like, you can let your body control your mind or your mind control your body, but whatever you want. And so for me, if I'm going to be cerebral, if I'm going to think about things, and I'm going to use my breathing to put me in a place where I can, pop the thoughts like bubbles and be of a more clear mind. And I think that breathing just seems to help every single condition, whether it's exercising, which involves breathing, walking, which involves breathing, or concentrated breathing training. I think that if I could give everybody in the world, every 7.72 billion on the planet, I would tell them to have a dedicated breathing practice.
All right. If I had to twist your arm, what about a not so faddish or popular talked about one? Do you have like a secondary, tertiary one? Or you're like, man, not the most common thing in the world, but I find huge benefit in this.
I have a so I was diagnosed with chronic migraine at age 21. It was triggered by a false medication of an oral contraceptive. I was on a low dose estradiol and they put me on high dose estradiol. And whatever that was triggered chronic migraine for a 22-year duration for me, although I haven't used oral contraception since I was 24. So it's been a 20-year hiatus, but the migraine stayed. And so with my study of migraine, I've it's gotten better from all the stuff that I've done, but the biggest difference as of recent in the last 2 months has been me using nicotinic acid,
Hmm.
niacin. And there's almost no research on niacin in migraine. It's almost all on riboflavin, which is B2, niacin's B3, or a magnesium. And I'm like, I think those things might be depleted by the process of whatever causes migraine and not necessarily the causative agents. But God, knock wood somewhere. Last month was the first month that I didn't have a migraine associated with my menses in years. And I'm talking maybe I just started keeping when I started teaching about migraine and lecturing about migraine, I felt confident enough to talk about it because I was actually getting a better stronghold on it
Hmm.
myself. And it's such a mysterious thing, the migraine, and very poorly understood for many, many decades. Is starting to get better. But I was starting to follow a pretty controversial person that was talking about niacin and all it's good. And I was like, I used to take niacin when I was in chiropractic school because it helped me with my Crohn's disease because it's a vasodilator. So I was
Hmm.
like, okay, well, I'm going to go back to it. And yeah, taking it consistently in August resulted in no migraine. I don't even like to talk about it because it's like I'm weirdly jinxing it. And then what it has done is it reminded me why I really like vasodilative things. Like for people that don't know what vasodilation is, opening of a blood vessel, it's vasoconstriction in certain regions of the brain. Your body doesn't like that. So the body will vasodilate, and that's when the migraine starts. But if you already
Hmm.
start out with a patent blood vessel, you'll never trigger the vasoconstriction. We don't know what triggers the vasoconstriction. We think it's one of these 23 genes or whatever. But I would say the most controversial thing I'm doing currently is higher dosing of nicotinic acid, the flushing kind. So sometimes my patients will see me with like a sunburned face because I'm in a full flush mode. They're like, did you get some sun? I'm like, no, I'm just flushing with niacin. They're like, oh, I can't handle that. But niacin was, I mean, if you start to do the deep dive in the research on niacin, holy crap, it does everything. What I'm really interested in is migraine. But the second one is that it raises HDL, which is the universal donor for lipoprotein. So I'm like, why isn't everybody with a high lipid profile on niacin? I don't understand. Like, oh, because it's not prescription. It's like
Peter
natural. That's
Attia was actually talking about that. I can't remember
oh
what the name of
great.
the research was, but he talked specifically about niacin as basically not only an adjunct, but maybe a primary
Yeah.
that somebody would try to see what would happen before you put them on medication.
Yeah. I could not loathe statins more. I'm not against all medications. I'm just against statins, and because they create so many biomechanical problems that come in, so much muscle pain and tendon. Like they say, it doesn't cause tendon tears. That's more things like Cipro and things like that. But I have people that are just so chronically sore, and then I'll say, well, are you taking CoQ10? Are you doing anything to raise your HDL? No. I'm like, well, not all cholesterol is bad, only LDL with a particular lipoprotein. And have you even had your lipoproteins read? No. Okay, well, did you know that the statins also lower HDL, so you don't have as many donors for apolipoprotein? No. Like, all they care about is this stupid number, this total
Mm,
cholesterol number. They don't eat, like, and a really good cardiologist, of course, will care about the ratios, but none of them talk about niacin. And then, of course, the niacin makes them uncomfortable, and they're like, "Oh, you'll be uncomfortable if on niacin. You're going to be way more uncomfortable on a statin. It's going to be all these little subtle things." And I actually like the flush; it feels good. It I don't know. I guess I feel like it's doing something, even if it's superficial. But I've felt like a consistent energy, which is really good. And I'm hoping it's one of the answers, getting closer to helping people with migraine, because
yeah.
I have people, I really want to believe that CGRP, that inflammatory chemical that promotes migraine pain, is the reason. But I have people that have taken, Ubrevely, which Serena Williams has made popular as a CGRP inhibitor, and then they like projectile vomit, or they have really bad. I think that idea is right, which is why they won the brain award. But I think that you're still not getting to the point of what can we do collectively to help someone with the systemic problem of migraine. It's not a headache, it is a systemic problem that also
Hmm.
has this particular type of headache. And being someone who deals with that, I mean, and your audience probably knows that if you have someone in your life with migraine, it looks like they feel like they're gonna die.
Hmm.
And if that happens to you every single month for a 22-year duration, which it has for me, again, I was teaching your classes. I mean, there were times where I would have to leave after a class and go throw up in a bathroom somewhere. I can't imagine
Hmm.
what some of the students may have thought. Now that never happens to me now, because I have much more better management
I
tools.
actually remember that because we
Do
thought you were
you?
pregnant. Yeah.
Oh yeah, that's funny. Yeah, like there were probably many times that I had to either leave a class, or
Yep.
my migraines were completely out of control. And now, of course, I'm approaching perimenopause, so I'm hoping, with fingers crossed, that the hormone fluctuations won't be as triggering. But I also don't want to stop my research on trying to understand chronic migraine. Chronic migraine is something
Hmm.
I'm always studying, and it has helped me a lot, doing a lot of different lifestyle changes. But the number one thing lately has been niacin.
We've been looking into a lot of CSF flow studies on migraines, which has been kind of interesting with patients too, which again,
Oh
it's
yeah,
all
scary.
presentation and, frequency and onset. Like it is very individual. And I think there's a general umbrella they all fall under, but it's kind of like,
Yep.
tendinopathy. I mean, you still have reactive, degenerative,
Yep.
tendinitis. Like there's all these things occurring that are under that kind of family for sure.
Yeah.
So it's
Yeah.
tough.
It's a tough diagnosis. And but I know that it's, I talk to my husband about this all the time, that it's my ultimate gift. Like your the thing that hits you the most becomes your biggest contribution to the
Yeah.
world. And I do know that, when I have a patient that is experiencing migraine, I am one of the best people on the planet to help them. I really feel that way, because I'm going to do the hard research. I have personally experienced it as well as professionally, and I know I can get them on a path to feeling less and less discomfort, even if it is a chronic situation.
Awesome. Well, last question here.
Yeah.
What is something that what's a knowledge gap that you found over the short term that you're like, man, I feel like I want to learn. I know that you're diving down the migraine and autoimmune tunnel, but you're already doing that.
Mhm.
What's something you're like,
Yeah.
dude, I don't know anything about this, or I know very little and I gotta find out more.
Yeah. I recently had a patient with a lot of these focal dysplasias within the liver, and I feel like it was a major hole in my understanding. I understand the anatomy of the liver, but the pathophysiology of these different focal dysplasias, I had no idea. And it turns out a lot of people have them, but when you go to the chiropractor, you don't necessarily share all that. But as I
Hmm.
start to build the trust tree with these people, I just got off a call today with someone with focal dysplasia, and like they have these nodules that form in various parts of their body, and it, of course, it's an immune reaction. A lot of it's considered to be, of course, either autoimmune or hereditary, because who else knows where to put it. And I'm trying to, and there's very little total research on those topics. So I'm trying to understand my best way to help them holistically.
Hmm.
The discussion I had with her today was intermittent fasting, she snacks constantly. And I'm like, that's not good for your glucose management system. And she goes, funny you should say, my, my fasting glucose is on the rise. And I'm like, that's cool. Have you had an A1C done yet? No. I'm like, let me tell you what A1C is. And so I can help in the ways that I understand, but she has me studying these different dysplasias very, very well. I'm about to start working with a Botox company, and I've done work with them before. They had me do some of the dissections, and then I teach them. I do the dissections, and I teach them where to inject for things
Hmm.
like, unmanageable cerebral palsy and cervical dystonia and even chronic migraine. Botox has some good results with, not for me, but for other people with chronic migraine. And what's fascinating is that you can like contribute to that, but not fully understand like
Hmm.
why it works. So I'm trying to do the deep dive on why the hell Botox actually helps these people. I mean, I know the simplicity of it, yes, you're paralyzing tissue, but like why does it relieve pain?
Hmm.
And so those are my two big deep dives right now. And like I'm failing abysmally and I need to get better at it.
Well, and I think I mean, what a great way to end, because in particular for a student, new doc, or, somebody that's been in practice for 20 years, like admitting that you're failing abysmally at something, but then being that opens doors for you to continue to learn. Like that's what we need more of, is just like, what gaps do I have? I'm willing to go out on a limb. But like you said, like a patient led you there. It's not that
Yeah.
the patient walks in, you have all the answers. You're literally just willing to go find as much as you can while you co-manage. And then eventually, you may be armed well enough that you don't have to co-manage as much. You can help these people a whole lot on your own, but that, it takes time.
Yeah. If you don't know about something and a patient tells you about it, don't assume that you don't have any responsibility towards it. That is the chemo reception holding up the couch. So if somebody is living with COPD and also coming to you for chest tightness or coming to you for back pain, those things are related. The better they control their COPD, the more they hold their adjustments. For you can treat them for dyspnea with your amazing adjustments, but if you also help them control their COPD, you look good in two ways. Not that it's
Hmm.
all about looking good, but it's about helping people. And you also get patients that are willing to listen to those parts too, because they'll refer people that are willing to do that hard work.
That's awesome. Well, as we wrap it up here, what do you have coming up course wise? Like what's coming up in the next month or two?
Okay, so I started working at my four schools last week, and it goes into full throttle next week after Labor Day. So I'll be spending 4 days a week in New York and 3 days in Colorado, which is really challenging for me because I adore my family. But my husband's incredibly supportive and wonderful, and he told me today that it's a gift it makes him really happy to watch me do what I'm put on earth to do. So if you can find a partner like that, I highly advise it. And then I'm teaching a couple of NKTs this fall, 3 NKTs, I think. We're doing ID Hong Kong this weekend, which is
Oh, wow.
awesome. I'm not going to be there. They're doing a viewing party, and we have an assistant in Hong Kong in Kowloon. And we're going to be, Anna and I are going to be on answering any questions for them. And then we have the Anatomy Angel TMJ course at the end of September. So keep an eye out for that if you're interested in TMJ. It's a 5-hour course. And if you're a chiropractor and you want to take the 15-hour version, you can come to the Somatic Senses in Vancouver. And we're going to do that the first weekend in December.
Ben Stevens is a stud, so I'll give him a shout
He is
out.
a
So
stud. He's the concussion god, right?
yeah.
Yes.
Well, awesome. And I'll link to as much of that as I can. I mean, I would make a iTunes like sheet that's a mile long if I put all that stuff in there, but we'll
Yeah,
put a
just
couple
email
upcoming
me.
courses.
Yeah, you can
Yeah,
email me if
we'll
you
put
have
in some
questions.
contact info.
Yeah.
But I can't say thank you enough, A, for coming on the show, but B, just doing what you're doing. Kind of being,
Oh,
leading from the front, from both an example standpoint, but just as a professional. And yeah, it was kind of funny. So we have a new physician in here that's, well, I say new, he's been in here for almost 3 years. We have a preceptor, and they both went to Logan.
oh,
And I was
nice.
like, hey, do you guys have any questions for Dr. Dooley? They're like, who's Dr. Dooley? I was like, that's the problem. That's why
Ah,
we need to have you. Like, I
yep.
was lucky to have you as an instructor,
Oh,
and
thank you.
you're still young in the teaching game.
Yep.
So like I hope that more people know who you are, because I think you set the bar for a lot of what we do. So
I really appreciate that. I take that really seriously. So anything I can do to help your audience, I'll do. So send over the questions.
Perfect. All right, we'll put that out there. Again, thank you for being on here, and
Thank
hopefully I can
you.
come to a ID class or some class
Yay.
sometime soon.
Yeah, we'll get you to host one in Birmingham.
That's right. We will for sure. I'll hold you to that.
Nice
All
to
right.
see you.
You too. Thanks for your
Yay.
time.
Bye.